Hi, this is Dr. Jay Patel talking today on the topic of child abuse, which is one of the important 22 don't miss diagnoses in medical student radiology. The goals of this lecture will include reviewing an acceptable definition of child abuse, and we will also be reviewing some of the key imaging findings in child abuse, which is also known as non-accidental trauma, or NAT, and we will be looking at these findings across multiple organ systems and imaging modalities. So the actual definition of child abuse is difficult to make. We don't have an acceptable one-line definition of what it could be. There's a wide range of views on what it could actually be, and that differs when you talk to clinicians, radiologists, ER physicians, and parents alike. But it's generally accepted that an abusive event is a willful assault on a child by a caregiver, and abusive acts are not generally exhibited by reasonable or prudent caregivers. The distribution of injuries we'll be talking about today will span the spectrum of neuroradiology, skeletal radiology, and abdominal radiology. So today we'll be looking at some head CTs, some skull films, some skeletal films of the long bones and appendicular skeleton, and also some abdominal CTs. Some of the fractures that we definitely have to be attuned to are the high-specificity fractures. If you see one of these fractures on radiographs from the ER, you definitely have to suggest to the clinician or ER physician that this potential patient could have been abused or been a victim of non-accidental trauma. So these fractures that we're looking for are classic metaphyseal lesions, which are also known by other terms such as corner fractures or bucket handle fractures. But today they're called classic metaphyseal lesions, or CMLs. Very high specificity for non-accidental trauma. Rib fractures, especially posterior rib fractures, are concerning. Scapular fractures, spinous process fractures, and sternal fractures are also highly concerning. It takes a lot of force to produce these types of fractures and these locations of fractures. So if we see them, you really have to be concerned about non-accidental trauma, and you must let the clinician know, because it is our duty to alert clinicians to this and potentially remove a child from an abusive environment. Because if they leave the ER and go back to the environment where they continue to get beaten and abused and shaken, there's potential for death or significant morbidity and mortality, and we need to stop that. So these are cartoons basically depicting a normal schema of bones. The epiphyses are typically the end of bones, the metaphyses, and you also have the diaphysis, which is the shaft of long bones. On the rightmost image, we are demonstrating a simple oblique type fracture or transverse type fracture with that black nice line, and we're also exhibiting some grayish periosteal reaction adjacent to the distal aspect of that bone. Here are two other cartoons demonstrating a normal bone on the left and an abnormal bone on the right. The new fracture line is pointing to something that's jagged and lucent and well-defined, identifying it as a new fracture. The line that says bowing is describing something that's bent. Children typically have plastic type bones, so if they bend or bow, that's also a fracture equivalent. The line pointing towards old fracture is showing basically two bumps across what used to be a fracture. So that new fracture line above, if you image it about a month later, it may have callus formation and look bumpy as it does down low. And periosteal reaction is the grayish haziness next to the mid part of this bone that we're seeing. This image, just keep it in mind for medical students. This may help actually see some of the findings on the subsequent films we're about to see. So this is a frontal and lateral radiograph of the bones in a child who has been a victim of non-accidental trauma. And on the left image, we are seeing a sliver of bone distally adjacent to the tibia, which is basically a classic metaphyseal lesion or corner or bucket handle fracture. On the lateral projection, we're seeing fractures here and here, anteriorly and posteriorly, and those are also known as classic metaphyseal lesions. If you see these fractures, let the ER clinician know, I'm concerned about abuse here. This is a high specificity lesion. The Child Protective Services likely needs to be notified. Here are 4 radiographs of the bones of the lower extremities in a child, also demonstrating similar findings as on the previous image. So on this radiograph, we're seeing corner fractures anteriorly and posteriorly in the distal tibia. Here we are seeing some periosteal reaction adjacent to the tibia. So this is normal cortex here, and adjacent to that is some periosteal reaction, which is concerning for trauma or non-accidental trauma. Here is also some periosteal reaction adjacent to the fibula. On this frontal radiograph, we're seeing periosseous reaction along the diaphysis and metaphysis of the tibia, and also along the fibula. So periosseous reaction in and of itself could be concerning for non-accidental trauma, but it can also be seen in other things such as infection or inflammation, and also it could be physiologic. In a child that's 1 to 6 months of age, you can see this phenomenon as a normal finding. So you got to really be paying attention to the history and the age of the patient as well. In addition, patients with cardiac defects or with PDAs that need to be kept open, these patients are typically on prostaglandins, and prostaglandin therapy can also produce periosseous reaction that looks like this. So the history is important. These images are basically showing the findings described on the prior films. The red circles or dots are outlining classic metaphyseal lesions or corner fractures or bucket handle fractures, and the right films are depicting periosseal reaction, and there is some bowing of that distal fibula on the left. Here is another radiograph demonstrating a fracture of the left femur. It's a through and through fracture, relatively acute, very lucent, and there's no other real bone formation around that fracture site. On the right femur distally, you're seeing some slivers of bone that are classic for classic metaphyseal lesions, and you are also seeing that in the distal left femur. On this frontal radiograph, you are seeing 2 slivers of bone. It's harder to see on the right side, but here we're seeing basically a corner or bucket handle type fracture in the distal left femur. This is another image basically demonstrating injury to the metaphysis. And yet again, in the humerus, we're seeing classic metaphyseal lesions proximally with just slivers of bone where they should not be. So just going over classic metaphyseal lesions, these are virtually pathognomonic of child abuse. You will see them in the distal femur, the proximal tibia, the distal tibia, and the proximal humerus most likely. They're discovered in about 40 to 50% of abused children less than 18 months of age, and almost exclusively seen in children less than 2 years of age. And typically these are generated by a manual to and from manipulation of the extremities, basically holding and shaking an infant by the hands or feet, or shaking the infant while he is held around the chest with the limbs whiplashing back and forth. These are some diagnoses that may be seen that could confuse a radiologist that's beginning in their training, or even medical students. Menkes kinky hair syndrome, which we've learned about probably in medical school. You see these hook-like bone formations at the end of the metaphyses, and this characteristic appearance is seen in Menkes kinky hair syndrome. It's not totally slivered off like we saw in those classic metaphyseal lesions. These are hook-like. And metaphyseal dysplasia, we just basically see here in this disease process irregularity of the metaphysis. We don't really see the classic metaphyseal lesion, but I could see how one could be confused with child abuse in this case. Here is a frontal radiograph of the abdomen, lower chest, and the femurs proximally, and we're seeing a through and through fracture of the proximal left femur. So we have a nice fracture that's not really showing any bone formation adjacent to it. Most likely this is an acute fracture. Here it's a few weeks later, and now we're seeing some periosseal bone formation, anterior and posterior aspect along the diaphysis and metaphysis of the femur, and we're seeing exuberant amount of callus formation. So typically when we see fracture lines, if it's a recent injury, it's going to be sharp and well defined, and with healing without immobilization, the fracture lines become sort of indistinct, and there may be blurring about 10 to 14 days out. You usually will start to have callus formation by 10 to 14 days, and it'll peak at 2 to 3 weeks. Hard callus follows, and there's bony remodeling at about 3 months of age up to 1 year. If the patients are immobilized and that fracture is reduced, this fracture here, if it were to be reduced and put back into normal anatomic alignment, it could basically return totally back to normal. But in this case, it did not. There's some fracture lines still visible here. There's exuberant callus formation, so this bone is still kind of healing. And here's another projection demonstrating similar findings. Callus formation adjacent to a fracture site that happened a few weeks ago, and periosseal bone formation adjacent to the diaphysis and metaphysis of the femur. Here we are seeing a spiral type fracture of the tibia distally. See this lucent line in the distal aspect of the tibia? If you see this in a toddler, it's actually not specific or highly specific for abuse. This could just happen as a growing fracture. Kids, when they're 2 to 3 years old, they basically start running around and they can get fractures like this. So this, you should not definitely suggest that this is abuse if you see it. Here is some cartoons depicting how posterior rib fractures may develop. So basically, the caregiver, who is not a good caregiver, is shaking this patient, and the compression by their thumbs and forefingers is causing the bone to fracture in the posterior aspect. So the posterior ribs are fracturing, and there's also fracture at the costovertebral junctions and even laterally. The little cartoon on the bottom right is depicting a compressive force against the sternum and basically deformity of the chest wall after a punch to the chest. Here is 2 more cartoons adapted from Green and Swiatkowski's Skeletal Trauma in Children from 1998, and here we are showing somebody pressing on a sternum and causing fractures of the ribs and possibly the sternum, and the other image demonstrating shaking of an infant and where the rib fractures will develop, basically posteriorly. This is a cartoon schematic animation of fractures developing, and this is shaking occurring. And on the next slide, here we see a fracture formation on the right side and an old fracture formation on the left side with adjacent callus formation. And I'm talking radiographic left. I'm speaking like a radiologist. So this would be, to me, my left, and this is on the right side. You get the picture. On this frontal radiograph of the ribs, it may be difficult to see, but there are fractures. There are multiple right-sided rib fractures right here and right here. Typically, if you can't see fractures too well on a film, physicians will order oblique films, or radiologists will suggest to get oblique films to bring out fracture lines a little bit better. So on these oblique films, now we can see multiple fractures right here, 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 and here, and here. And some of them with callus formation, so some of these are in healing phase. The fact that they're kind of lateral, some of them are kind of posterior, that strongly correlates with abuse because the mechanism that generates these fractures is relatively specific. Other fractures that are very concerning are first rib fractures. Those are considered virtually diagnostic of child abuse since they require considerable force to produce. These arrows are pointing to some other posterior rib fractures, some with adjacent callus formation, signifying that they weren't definitely acute. Here are more films with rib fractures and adjacent callus formation, and on the right side there's exuberant periosseal formation and callus formation of what used to be in fracture probably a couple of weeks to months ago. Now we're going to look at some abdominal findings in child abuse. So the green is the liver. The brown with the white donuts inside are the kidneys, the yellow is the vertebrae, the black is the pancreas, the red is the stomach and spleen region, and here we have a fist to the stomach. Popeye got mad, started hitting a child, and here he did it again, and he shattered the liver. There's a liver laceration, and there's also a pancreatic laceration, and that little red ball inside the duodenum is concerning for a duodenal hematoma. So you can imagine if you have a child who's punched or kicked in the abdomen or chest, the force is going to go from anterior to posterior and it's going to injure everything in its path. So if you're punched in the mid-stomach, it's going to maybe produce a liver laceration, it may produce an adrenal hemorrhage, it may produce a duodenal hematoma, and it may lacerate the pancreas because when all these things get squished up against the vertebrae, they tend to get damaged. So here's another schematic describing what happens with the force and what kind of findings you'll see, namely liver lacerations, pancreatic injury, duodenal hematomas, and adrenal hemorrhages. That's what we're looking for on the abdominal films, CTs, and ultrasounds on these patients. So on these 2 images, we are seeing some fluid accumulating in the abdomen, and we can see that here and here. And also the duodenum has some high density fluid within its wall. That's concerning for a duodenal hematoma. Here we are going across the spine and we're looking at a structure that's anterior to the aorta and anterior to the IVC. And that is where the third portion of the duodenum will cross across the body. And if force is directed from anterior to posterior from this direction, punch here, it'll make the bowel wall compress against the spine and also even the pancreas, and you may develop a duodenal hematoma. This imaging is highly characteristic of non-accidental trauma. This may be confused with other diagnoses such as lymphoma, especially if the patient's LDH was elevated, maybe with pancreatitis if the pancreatic enzymes were elevated, but if we see these findings, have to definitely consider the potential for child abuse and non-accidental trauma. This is a schematic or a cartoon demonstrating what happens when a baby is shaken. Babies kind of have floppy heads, so when they shake it looks like this, and they can get cervical spine injuries and even hemorrhages in their brain just from the shaking. Notice the legs demonstrating that wispy appearance from the shaking back and forth. That will typically produce a classic metaphyseal lesion. So I'm not going to delve too deep into the actual diagnoses and findings here. I'll just kind of go over them quickly. You can also see these on the other neuroradiology podcast regarding the 22 don't miss diagnoses in medical student radiology. But here we are seeing the typical appearance of an epidural hematoma. This is a high impact fracture. We can actually see the fracture line in the right frontal skull. This is a very concerning hematoma because it typically indicates an arterial injury, and we have to consider abuse in this situation. Here we are seeing two axial head CTs without contrast, and we're seeing some low density fluid surrounding the sulci and anterior cortices bilaterally. So up here, up here, up here. There's some more dense material up here, and there's some more fluid density up here. So the brain tissue is not going out all the way to the cortical mantle. It's not going all the way to the inner table of the skull. So that means that there's something occupying that space. And what's occupying that space in this patient is subdural hemorrhage in mixed ages. The darker ones are older, more chronic appearing blood, and the brighter areas that are outside of the sulci in the extraaxial space are concerning for more acute bleed. So this is multiple different bleeds. Multiple different ages, highly concerning for abuse. This is a non-contrast head CT, and we're seeing some very bright material in the extraaxial space on the left, and also some low attenuation or dark material in the left frontal and to a lesser degree in the right frontal region. This is concerning for mixed-aged subdural hematomas. Not only that, we have some midline shifts from the left to the right, so that's concerning. This patient may have to get evacuated by neurosurgery if it gets bigger or the patient's not mentating well, and these findings are concerning for abuse. Here is a T2 weighted axial magnetic resonance images demonstrating T2 bright or lighter looking areas in the extraaxial subdural space, and also T2 dark area right here. The dark area is acute blood, the light area is older blood. So we don't have to delve too deep into the MRI findings, but this is concerning for mixed-age subdural hematomas in the extraaxial space, concerning for non-accidental trauma. Here is another image, basically a flare image demonstrating increased signal intensity in the extraaxial spaces posteriorly on the right and also laterally on the left and also posterior on the left. And excuse me, it's actually a T1 weighted image, and the T1 brightness of this suggests that it is met hemoglobin and a subacute hemorrhage, so subacute subdural hematoma. This is a diffusion weighted image, which basically tells us if it's bright, there is ischemia or infarction in that area. So in the left temporal lobe in this region, there is an area of brightness that is concerning for ischemia or infarction. Subdural versus epidural hematomas. This has gone over in other podcasts involving neuroradiology. Basically, subdural hematomas are going to look more crescentic in shape, and epidural hematomas are going to look more lenticular in shape. Epidural hemorrhages are typically arterial. Subdural hemorrhages are occurring because of tearing and bridging veins. And these can also be seen on other neuroradiology podcasts. This is a subdural hematoma occurring because of shaking of the brain. And here we've developed blood and a crescentic collection. If it's in mixed ages, you got to consider non-accidental trauma. Epidural hematoma, baseball hits the head or punch to the head, and they develop an arterial injury. It looks more lenticular in shape. Look for the right to left midline shift or any signs of herniation or abnormal mentation. Notify neurosurgery. Here is a sagittal or lateral skull radiograph, and here we're seeing in likely the parietal bone an abnormal line that should not be there. This is the squiggly looking lambdoid suture on one side, squiggly looking lambdoid suture on another side. These are the coronal sutures right here, and this is a suture that is not normal. That is likely a fracture. So on this film, on the frontal film, we are seeing a fracture right here. Nice jagged line that is not a suture line. This basically goes over the spectrum of findings in child abuse across multiple modalities. I hope you enjoyed it, and stay tuned for any updates in the future. Thank you.